Hello, welcome to this short teaching video. I'm Boon Seng. Today I'm going to talk about the approach to haemoptysis, and this lecture is catered specifically for the undergraduate internal medicine rotations. Well, this lecture has three learning outcomes. Number one is to describe a logical and practical approach to assess patients with haemoptysis. Number two is to list a differential diagnosis of haemoptysis. And lastly, to describe the overview of management of haemoptysis. Specifically, we are going to discuss pulmonary tuberculosis, bronchogenic carcinoma, and renal pulmonary syndrome. Well, to better understand the content of the lecture, it would be essential to recall and reactivate your prior knowledge on hemostasis, particularly on the formations of platelet plaque and coagulation cascade, vascular supply of pulmonary tissues, and the physiology of systemic and pulmonary circulations. The first step in the approach to patients with haemoptysis is to take a good history. We need to differentiate between a true haemoptysis versus a pseudo-haemoptysis. A true haemoptysis defined as a coughing out blood from the lower respiratory tract, defined as the airway below the vocal cord. Whereas a pseudo-haemoptysis can be ranging between bleeding from the upper airway or patients vomiting out blood instead of coughing out blood. It is important to note the onset of the haemoptysis, the amount, and the color of the blood that patients are coughing out. It is helpful to note whether there is preceding trauma, aspiration, or choking, or take a good drug history, particularly on the use of blood thinner, antiplatelet, or anticoagulant. We will ask the associated systemic symptoms based on our clinical suspicions on the differential diagnosis. If we suspect the pulmonary tuberculosis, we should specifically look for fever, night sweat, loss of weight, loss of appetite, neck lump, contact history, and the social circumstances the patient is from. Whereas for lung cancer, we should ask about smoking, quantify the amount, cough, breathlessness, constitutional symptoms. For pulmonary embolism, we need to inquire the recent surgery or immobilizations and whether there is unilateral limb swelling or there is a history of malignancy. Lastly, for renal pulmonary syndrome, we need to ask specifically about hematuria, reduced urine output, fever, and breathlessness. After taking a complete history, we will next to perform a physical examinations to patients presented with haemoptysis. We should specifically look for signs of circulatory shock from excessive bleeding, which are reduced alertness, hypotension, tachycardia, reduced urine output, or cold periphery. We should look for signs of respiratory distress as well, because for pulmonary hemorrhage, patients can have tachypnea, tachycardia, cyanosis, use of accessory muscles, and intercostal involving. And screen for signs of coagulopathy. Look specifically for bruises, petechia or ecchymosis, hematoma, or any visibly bleeding. We should proceed to examine the chest. For mass or consolidation lesions, patients will have reduced chest expansion, bronchial breathing, and cause crepitations. For collapsed lesions, patients will have reduced chest expansion as well, but dull on percussion, reduced breath sound, and depending on the locations of the collapse, the trachea may deviate. Investigations of a patient with haemoptysis has two purposes. Number one is to assess the complications of bleeding. Number two is to find the cause of haemoptysis. For complications of bleeding, we should look for full blood count. We would expect anemia, leukocytosis, or thrombocytopenia. The patients may have deranged coagulation profile from prolonged PT/PTT, low fibrinogen, or positive for D-dimer in the patients with disseminated intravascular coagulations. We should take blood gas and lactate as well because patients may have respiratory failure with lactic acidosis. To find the cause of haemoptysis, we can perform a chest X-ray. We would expect airspace opacity plus or minus obvious mass. Contrasted CT thorax to look for ground glass opacifications or consolidations from pulmonary hemorrhage. CT angiography to look for source of bleeding, and sputum for AFB and MTB culture, bacterial and fungal culture. Lastly, if you worry about things of renal pulmonary syndrome, we should send for autoimmune serology such as anti-nuclear antibody ANA, anti-dsDNA, C3, C4, ANCA, and anti-GBM. Next, I will proceed with 3 cases to demonstrate the overview of management for patients with haemoptysis. Case 1 will be pulmonary tuberculosis. This is a case published by Subay et al. Now, the author described a 25-year-old Indonesian lady who presented with a 2-month history of haemoptysis productive of 150 ml of blood per cough with dyspnea. She has lost 5 kg in last 1 month, and remotely she had haemoptysis 2 years ago, which resolved spontaneously. In the past medical history is significant for pulmonary tuberculosis diagnosed 5 years ago. She completed 6 months of anti-tuberculosis therapy, but there's no reassessment done. For family and social history, she is a passive smoker and there's no family history of malignancy. On examinations, she is tachypnic with a respiratory rate of 26 breaths per minute, oxygen saturation of 96% on 2 liter nasoprong, blood pressure of 120/70, she's pale, there's a reduced chest suspension on the left, and a downward percussions on left upper to mid zone associated with reduced vesicular breath sound. Now we look at the investigations that have sent for her. She has HB of 8.4, which is anemia. Ziehl-Neelsen and gene expert test was negative. On the right hand side of the slide, you can see a chest radiograph of this patient. The abnormality is on the left hemithorax. And we can see an opacity on the left upper to mid zone of the lung field. This slide shows the selected image of a CT thorax non-contrast done by these patients. We should focus on the left hemithorax. The abnormalities is on the left upper lobe, where you can see a cavitatory lesions at the left upper lobe with a aspergilloma. Well, the specific management of this lady who has aspergilloma complicating an old pulmonary tuberculosis is a surgical resection, and we should perform a PEG cell transfusions and give antifungal therapy. Now, case 2 is about lung cancer, and this case report was published by Takizawa and colleague in 2024. The author described a 63-year-old male who presented with sudden onset of right-sided chest pain and dyspnea. On examinations, the patient was hypoxia. The SpO2 on room air was 60%. Then the treating team immediately put on high-flow oxygen mask followed by non-invasive ventilations. The patient developed fast atrial fibrillations and hypotensions in the ward, necessitating an oral trachea intubations. He subsequently developed a massive haemoptysis, and the blood actually flowed to the unaffected lungs. The team performed a bronchoscopy and found that there's a right bronchial mass. Well, this slide shows the chest radiograph and the selected image of the CT thorax, plain and contrasted. We will focus on the left-hand side of the slide, which is a chest X-ray. The abnormalities is on the right hemithorax, where you can see there's collapse of the lungs with the tracheal deviations. The abnormalities is on the right upper lobe. The second image, the panel B in the middle of the slide, shows that the mass actually invading into the main bronchus, right main bronchus. While the third panel of the contrasted CT thorax on the far right of the slide, it shows that the mass is invading into the pulmonary trunk, and that could explain why the patient is having haemoptysis. The specific management for patients with invasive lung mass involving the great vessels and main airway is to administer a timely ventilatory and circulatory support. We need to transfuse blood products such as PEG cell, platelet, and plasma. We can offer radiotherapy or targeted therapy to the lung mass to reduce bleeding. Now, the last case is on a rarer entity, which is the renal pulmonary syndrome, published by Sadi et al. In 2018. The author described an 85-year-old man presented with progressively worsening shortness of breath and pleaded edema for several days. 1 month before his current presentations, the patient was admitted with acute kidney injury requiring initiations of renal replacement therapy. He was diagnosed with palsy-immune necrotizing glomerulonephritis with crescents. Of note, his comorbid of hypertension, diabetes mellitus, and prostate cancer. On examinations, the patient was hypoxic and is in respiratory distress. There's a use of accessory muscles, auscultation of the lungs revealed bilateral crackles. There's pitting edema of his both extremities. Now we look at the investigations of this gentleman. He has chronic anemia, thrombocytopenia, and leukocytosis. There's renal failure, the ANCA was negative. Now we look at the chest radiograph of these patients on the right hand side of this slide. On the chest x-ray, we can see that there's a dialysis catheter inserted on the right interjugular vein, which is in situ. Looking at the lung fields, the patient has bilateral scattered opacity in all lung zones. A bronchoscopy was performed on these patients and there's increasing bloody return on sequential lavage on the same segment of the lung, which was diagnostic of diffuse alveolar hemorrhage. On the right hand side of this slide, you can see 3 bottles of bloody lavage sample. From the left to the right, there's increased level of bloodiness on the sequential wash, which is diagnostic of diffuse alveolar hemorrhage. So this is a case of a renal pulmonary syndrome. The specific management of this ANCA-negative renal pulmonary syndrome is to give respiratory and circulatory support, timely renal replacement therapy. We need to give a pulse steroid and followed by plasmapheresis and immunosuppressant. We have come to the end of this short lecture on approach to haemoptysis. We've covered the presenting symptoms, examination findings, key investigations, and the principle of management. If you need to ask questions, please leave your questions in the comment sections. Otherwise, happy revisions, and I hope to see you next time. Thank you for your attention.